Question number 4th. First, you should understand the question appropriately. Then, you should go the option. First, suppose you think a 28 years old female with background of Crohn's disease presented with her general practitioner, that's mean GP, complaining of generalized fatigue and shortness of breath on exertion. The most important point here, generalized fatigue and shortness of breath on exertion. Fatigue and shortness of breath of exertion. She was recently discharged from hospital after a flare of her inflammatory bowel disease, that's mean IBD. She was recently discharged from hospital after a flare of her inflammatory bowel disease, but symptoms are now controlled. After being commenced on azathioprine, that's mean immunosuppressive agent, or it is one of the DMARD, disease modifying anti-rheumatic drugs, azathioprine. Now routine blood test arranges hemoglobin 106 gram per deciliter or 10.6 milligram per deciliter. This is almost in normal range. Platelet 180 into 10 to the power 9 per liter, normal in range. White blood cell count 5.6 into 10 to the power 9, which is normal in range. ESR, erythrocyte sediment rate 5 millimeter mercury in first hours, which is also normal in range. Prothrombin time 11.6 seconds, which is also normal in range. Activated partial thromboplastin time APTT 29 seconds, which is also in normal in range. Fibrinogen 3.2, which is also in normal in range. D-dimer less than 420 nanogram per milliliter, which is also normal in range. Ferritin also is decreased. That's why storage iron is decreased. Ferritin is the storage form of iron, whereas iron is the absorbed form of iron. So patient storage iron is decreased. Very important clue. Vitamin B12 level 4.6 on nanogram per liter, which is also in normal range. Folate, that's mean vitamin B9 6.4 nanomole per liter, which is also normal in range. Reticulocyte 0.9%, which is also normal in range. Given her blood result, that's mean above blood result, she is comments on appropriate replacement therapy, that's mean decreased iron and iron replacement therapy is given. Which one of the following supplement would improve her response to treatment? That's mean here indicates which factor increase absorption of iron. The next option should be followed. First one is thiamine, vitamin B1. This is not increase iron absorption. This vitamin B1 causes heart failure very white very and dry very. Heart failure causes as a result of white very. Peripheral neuropathy also. Oleic acid, this active form of vitamin D, not increase in iron absorption. It helps in calcium absorption. Riboflavin, vitamin B2, not help in absorption. Ascorbic acid, another name is vitamin C. This is the answer. It help in absorption of iron. It helps in absorption of iron. HCl also absorption increased iron. Hydrochloric acid in stomach. Niacin, that is vitamin B3, form of vitamin B3. It not causes of increase iron absorption. When vitamin B3 or niacin deficiency occur, then there is several problem like 3D. Or first one is dementia, then diarrhea, then dermatitis. Diarrhea, dementia, dermatitis. This is the 3D plague form. Now here vitamin C, ascorbic acid supplement can aid iron absorption from the gut by conversion ferric form to ferrous form. This is the patient from iron deficiency anemia as a result of her Crohn's disease. It is a form of inflammatory bowel disease, IBD. IBD include two diseases. One is Crohn's disease, second one is ulcerative colitis. This is evidence from blood test with reduced hemoglobin and ferritin level. Note her hematinics blood test like vitamin B12, folic acid within normal range. In order to replenish her iron store and increased her hemoglobin, appropriate treatment would be common sense means ferrous fumarate. Iron is best absorbed in a small intestine, duodenum. Ferrous form. Ferric form is more difficult. It is intestinal mucosa to absorb. By additional ascorbic acid to oral iron therapy, there is increased conversion of ferric form to ferrous form in the gastrointestinal tract. This helps the proportion of ferrous iron which is readily absorbed. This improved response to treatment. Thiamine deficiency is implicated in development of Wernicke's encephalopathy, Korsakoff syndrome. This is alcohol dependency. There is usually concomitant poor nutritional intake. It plays no role in absorption of iron. Cholecalciferol central role in maintenance of normal calcium and phosphorus level in conjunction and parathyroid hormone. Vitamin D supplementation improves intestinal absorption of calcium but no effect on iron absorption. Now riboflavin is a vitamin which works as a cofactor for number of enzymes involved in energy release from carbohydrate and fat. Riboflavin supplementation has no role effect on iron absorption from gastrointestinal tract. Niacin, vitamin B3 or nicotinic acid is important assisting DNA replication repair as well as acting coenzyme for metabolism carbohydrate and fat. Deficiency causes plague, dried, dermatitis, dementia, diarrhea. Supplement of niacin does not contribute iron absorption. This is the question. Thanks.